And without further ado, I would like to be able to present our very first presenter. We have here Dr. Sivaraman. She is a pediatric rheumatologist and associate professor of clinical pediatrics at The Ohio State University Nationwide Children's Hospital. Hopefully I got that right. And we are delighted to have her present and to provide us with an overview of what you can expect here for this presentation. So thank you again and welcome.
First of all, thank you so much for that kind introduction, Sarah, and thank you so much to Joyce and Kaylin for all their hard work in preparing this conference. I will say that this has been quite a journey, all the planning that has gone into this, and really kudos to the whole Vasculitis Foundation team on preparing this conference. Despite all the challenges of the pandemic and the challenges of the changes, being in person and then being virtual and all of that. So it's nice to know that the Vasculitis Foundation has such a worldwide reach. And I would like to say that, we as professionals that deal with pediatric vasculitis are very passionate about this group of diseases. And I hope you see that in our presentations today. So I will be presenting just an update on pediatric vasculitis. This will seem like kind of a very rapid fire overview, but I will not go into detail on individual diseases, and there will be time for that and questions later on. But I really wanted to kind of give that more high level overview. So I'll start out by saying we wish we were here on the left. We are all looking forward to meeting in person, the Chicago skyline right there for you. I myself was looking forward to being in Chicago in July, which is a nice time to be in this big city and enjoy all that it has to offer. But instead, we're here on the right, living our world on Zoom. This picture is from our vasculitis conference that we had among the research group that I'll talk about as we go through this presentation. But this is part of our research group within a childhood research network called CARA, or the Childhood Arthritis Rheumatology Research Alliance. And you might hear some references to that later. So here we are, and it's great that all of you have taken this time on a Saturday afternoon or whatever the time might be in your area to join this conference and be able to learn a little bit about vasculitis. So this is a group of diseases that the average person has probably not even heard of. But if you think about it, whatever brings you to this conference today, there is some connection to a person who has a vasculitis disease of some form. But this just this image here just shows you how diverse the presentations can be. And so each of you, no matter how you're connected, or if you're a patient with vasculitis, might have had any of those symptoms, whether it started in your skin or your kidneys, your heart, lungs, brain, eyes, pretty much any organ of the body, because if you think about it, vasculitis is related to inflammation in blood vessels, and blood vessels are everywhere in our body. And so affecting those blood vessels, we could see either blood loss, the fancy word for which is hemorrhage, loss of blood flow, the fancy word for which is ischemia, and inflammation, which just means kind of think about it like it's on fire. So here we have different parts of your body that are basically on fire, which could be major vital organs. So that definitely is not something to take lightly. We then have, say, a person in front of us with one of these symptoms, and we might put you through this whole battery of tests. And it really is a diagnostic journey. And I'm sure each of you has your own story to share. I myself, from my years in practice, can share a number of cases with you, each with a completely different journey. And so we might run this whole battery of tests. It might involve blood tests, urine tests, some fancy antibody tests that most people can't even pronounce or spell out. And that includes physicians, other tests of different organs that are managed by different specialists, whether it's the cardiologist, the lung doctors, the kidney doctors, the skin doctors, the eye doctors. There's any number of specialists that might be involved, the radiologist. We need physicians of every single specialty to come on board with these patients in some situations. So how common are these diseases? So you will see that these are not common diseases. So I'm sure each of you that are here, if you're connected to a person with vasculitis, these are rare diseases. So as alluded to at the beginning of the session, these diseases definitely fall within the category of rare diseases, which then have their own challenges. And we'll allude to that later on during the presentation. So the total incidence of these conditions in the pediatric or childhood age group is believed to be 20 per 100,000 under the age of 17. Now, the two most common ones are probably not even diseases we're going to talk about much, and probably not even diseases that those patients are even on a session like this, because those are the two conditions that are called HSP, or Hinox-Schondlein purpura, and Kawasaki disease. And those two diseases, HSP is something that's pretty self-limited, much more common in children. Most of those patients aren't even followed long-term by rheumatologists. Kawasaki disease, on the other hand, typically can affect the heart. And so that's a condition that's followed more by cardiologists than rheumatologists. So neither of those conditions are in the category that we're even talking about. So we're talking about even less common diseases. And why do we worry about these diseases? Because the end result can be pretty severe. So some of the problems that can happen are irreversible. It can lead to pretty significant degree of illness. It can even lead to death. So this is definitely not something to take lightly, because the consequences can be literally fatal if the diagnosis is delayed. So we have gone through, over the past several decades, multiple iterations of what we might name these diseases. So if you hear different names, and certain doctors have heard certain names and others haven't even heard of that name, you're not alone. We as physicians are in that category. Our colleagues in other medical specialties are in the same category. So we have changed some of the names of some of these conditions. Again, some of that is related to the original terminology having been related to Nazi scientists. And so we wanted to get away from those names. And some of them are based, the newer names are based on the pathology, which is basically what we find in the tissues when we run all those tests. So I like this schematic. I show this to my medical students and residents all the time, because it just shows you a breakdown of how, depending on the size of the blood vessel, the symptoms may vary. So you might start out with a very large vessel vasculitis, which is on the left end of the screen here. The classic example for that would be Takayasu arteritis. And I know some of you have that diagnosis. That affects the largest blood vessels in the body, of which the classic example is the aorta. So that is your largest blood vessel. So you definitely can imagine that that's not something you can take lightly if that vessel is affected. Then we go on to the medium vessel at the top, which includes a condition called polyarteritis nodosa, which can affect different organs, but involves the same size of vessels as Kawasaki disease, which I mentioned. And then I'm going to come to the lower part of the screen, where you see the group of conditions called ANCA-associated small vessel vasculitis. And so this includes a group of conditions that we'll talk about in a couple minutes. The new names for these are microscopic polyangiitis, or MPA, one that is called granulomatosis with polyangiitis, or GPA, and the old name was Wegener's. And then there's a condition called eosinophilic granulomatosis with polyangiitis. That's a mouthful. And the old name for that is Churg-Strauss disease. And then at the very top, you have a group of even less common conditions, which are called immune complex vasculitis, which I won't go into in much detail. But this just gives you a little bit of a breakdown. Obviously, in the interest of time, I cannot go through each of these, but each of these might have slightly different treatments, but we're going to just talk in general about just overall treatment for some of these conditions. So this picture just shows you the Hinox-Schondlein purpura, which I said was the most common. The new name for that is IgA vasculitis. And the only reason I mentioned this is because it's the most common vasculitis in childhood. This is usually younger children. Often there's an infectious trigger, like even a strep infection. So something as common as a strep infection can lead to this. And most of these children do well, but sometimes we do see them get pretty sick in the hospital, because they can have bleeding into their intestines, and they can also develop kidney disease later on. So again, it's a condition that doesn't cause the same degree of severity or long-term issues, but it's something that we still need to monitor. So I like to take a little pause and tell you how we might kind of rethink some of these diseases. So this is an image I like to show my students, and it's basically an optical illusion where we try to ask if the stairs are going up or down. And so what you see here is basically, it's meant to be an illusion. And what you see is that the stairs, if you were to start, say, on this right side here, you feel like you're going down, and then you feel like you're going up, and then it looks like they're going up, but then somehow they ended up back where they started. And so this often happens with our diseases in rheumatology, where you think, oh yes, I have the answer, the kid has HSP, I've got it all figured out, they're going to be fine, it's not a long-term disease. Well, things aren't really going according to plan, and something might change along the way. And so that's when we often have to take a step back and say, okay, what did we miss here? Is there something else going on? So here you will see that we sometimes have, based on what we're seeing, we might have to have all kinds of different treatments that we might think about. So again, just mentioning to you another challenge that we face. So one challenge was the diagnosis, but another big challenge that we face is treatment. So while you might have to run all of those different tests on all the different organs, we also have to sometimes take a step back and say, okay, now we're dealing with a little child. How are we going to actually tailor that treatment to that particular child and that particular disease? So here, what you see is that the majority of children, the schematic on the right shows you how, based on the age of the child, we might have completely different treatments. So for a lot of what you might hear about vasculitis and a lot of the treatment that you might hear is really tailored for adults. Oftentimes, as the large trials are done in adults, and we do not have the same advantages of having large trials to say, this is the best treatment, this is what we know is going to work for your child. And so oftentimes we have to adapt something that we have from adult patients. But in children, what are our different challenges? We have to think about steroids. So this is something we're thinking about a lot in recent years, because children are often subject to large doses of steroids, and that could affect their growth and development, their bones, put them at risk for infection. And so it's definitely not something to take lightly. We also have to think about the long-term consequences of our medications. So one example is cyclophosphamide, which is basically a chemotherapy medicine that we often will use in our patients because they have lung or kidney disease, and that's not something we can take chances with. We also have to think about whether these children are taking their medications as they're supposed to, also called compliance or adherence. We also have to take into account social factors. For example, things like a medication like methotrexate, we have to also counsel about alcohol use and pregnancy. And so there's all of these different factors that we have to kind of put into a bundle and be able to communicate with our patients, which is definitely not easy. And last but not least, we also have to take into account cost and logistics. But definitely when we're dealing with the risk of something that's long-term and can basically be organ or life-threatening, it's something that we have to sometimes move quickly and be able to provide the best treatment. So I will go through, in the interest of time, I guess I'm already at my 12-minute mark. So I will go through a little bit of this in a little bit faster pace. So basically, this is a patient who's a 14-year-old male who comes to us with an unexplained anemia and dark urine. So I will not go into the details, but what this patient gets diagnosed with is this little group of diseases at the bottom, which is also called the ANCA-associated vasculitis. So this is a group of diseases that can affect the heart and lungs. It is named after this antibody test that's called the ANCA, or anti-neutrophil cytoplasmic antibodies. And so this is a test that we run in the lab, and it just shows you a picture of what the lab sees, because there's two different patterns of this. The one on the left is what we call the cytoplasmic ANCA, and the one on the right is what is called the perinuclear. And these are basically granules that are within your white blood cells that in the blood that we can test on a blood sample. And these help us to be able to just classify a little further as to what type of vasculitis a patient might have. So then we have on here, you actually see on this slide, you're seeing on the left panel, you're seeing a picture of a patient with this condition, which used to be called Wegener's, but is now called GPA. And this basically is showing you that there can be changes in their sinuses, and they can get what is called a saddled nose. So it's basically just where the bridge of the nose can actually get sunken in as a result of this disease, even years down the line. The panels on the right show you what we might see on the inside. So while on the outside, this patient, if you looked on the left, that patient may not really have a lot of symptoms, but they might actually come in very sick also to the hospital, where we have to do a lot of those tests that I had mentioned. So here on the right, you're seeing the top panel showing you what a lung biopsy would look like. So this is where we actually go down into the lungs with a tube that's called the bronchoscope. And then we try to get some tissue, or we might actually get a lung biopsy in patients that are stable. And what we're looking for in that biopsy is the vasculitis. So vasculitis is basically inflammation in blood vessels, no matter what organ we're looking in. So in the top panel, you're seeing in the lungs, where it's basically the lung tissue is not supposed to look like that. It's more of an area where there's air filtration. And here the blood vessels, like you see on the right, is a blood vessel that's surrounded by the blue, which is white blood cells, which indicates the inflammation. In the panel below, you're seeing a sample of a kidney on a kidney biopsy, when somebody had a kidney biopsy for vasculitis. And the kidney, again, is a filtration system to be able to produce urine in a healthy manner. And here on the right, you're seeing where that's the central part of the filtration system of the kidney, which is called the glomerulus, and that's what's inflamed. Basically is being replaced by white blood cells and then scar tissue. And that can lead to basically kidney failure, where you might need dialysis or a transplant if it's untreated. So while the one on the top in the lungs would lead to bleeding in the lungs, and these patients can get extremely sick very quickly, end up on a ventilator and even die, the one on the bottom shows you the kidney disease, where they sometimes will not have a lot of symptoms. And the first sign is that they're already in renal failure. So what can we do, and what can you do? So basically, the big thing that I would like to kind of highlight from this presentation is that you can get involved. And so there's different ways that you can get involved. So just being here today is a big thing that you're already doing to get involved. I'll end with the last couple of slides just talking about some ways that you can get involved. So what we as a group, and I mentioned that we have a group of investigators that are keenly working on vasculitis. We're fortunate to have what is called a registry that is based out of the University of British Columbia in Canada, in Vancouver. And Dr. Cabral, who's mentioned there on the right, is the head of this rheumatology division, and he is also the head of our one of the co-leaders for our vasculitis research group. And so he is also the principal investigator for the registry that basically connects information about outcomes for children with vasculitis, and we're helping develop different treatment plans and different forms of research to really be able to improve our clinical care for children with vasculitis. So I'll just highlight here couple of things that have come out of this group. And one that I will highlight is called what we refer to as the Consensus Treatment Plan, or CTP. And again, you don't have to know the name of what this is, but all this is that we have developed some treatment plans, given the lack of large research studies in children with these diseases. We have developed some treatment plans that we can actually try to see in terms of comparison and see which one works the best. So the two big medications that you see here are cyclophosphamide and rituximab. Some of you might be familiar with those medications if those have been mentioned to you with your type of vasculitis. And so the first arm is what is called induction, and then the second arm is what is called maintenance. So the first 6 months, you go through the phase of induction, where we basically try to get the disease into remission. And then after that, for the next 2 years, we basically have a maintenance phase to be able to get the disease into remission. So these are the different phases. And then on the next slide, I'd just like to show you how at each stage, we do different visits where we take blood samples, we ask how you're doing, and then we collect a lot of data, even related to what patients are feeling, how they're doing, something that's called patient-reported outcomes. And so the registry has already captured samples on over 150 patients at 21 sites in 7 countries. So just to be able to get this kind of data in children with vasculitis is extremely powerful. Another example that we talk about with the research is how we can actually find new targets for treatment, how we can actually find new ways to diagnose the disease. And this is a good example of how the disease might present. So this is an example showing you an iceberg. And at the very top, you're just seeing the tip of the iceberg, which is where you're seeing the clinical disease and the signs and symptoms. But really under the surface, we have a lot of subclinical disease where we might actually not even be able to diagnose it. And so that's another area where there's a lot of research that's being done by this group. So really what I'd like to kind of end with is just talking about hope and how, having this network is really an important way that we can try to be involved, and having patients as part of that network is also a huge effort. And